In this presentation, I will give an overview of my commitment to CPD. I'll also include how CPD impacts clinical effectiveness and service development. I'll undertake a critical reflection of my current professional development needs and an outline of goals relating to improving my clinical effectiveness and service development and how I will carry these forward in my graduate practice. Kalman describes CPD as the longest and most continuous phase of a health professional's education. Gunn highlights its role in developing confidence and competence throughout practice. The HCPC requires that all registrants carry out regular CPD, engage in a variety of learning activities, reflect on how their development improves practice, and participate in audits throughout their career. The CSP note that continuous professional development is essential for keeping knowledge and skills current, evidence-based, and aligned with the best clinical practice. Maintaining a CPD portfolio is also important. Maintaining a CPD portfolio is also a professional requirement. It supports fitness to practice by demonstrating that we are safe, confident, competent, and reflective practitioners. CPD can take many forms: structured courses, peer learning, journal clubs, clinical audits, professional networking, self-directive learning, and reflective case studies. Personally, I record CPD on TURAS, which integrates well with the NHS, and this can also be done through Excel sheets or the CSP portfolio tool. CPD is closely linked to evidence-based practice. It helps physiotherapists make informed decisions using reliable sources such as NICE, SIGN guidelines, Medline, and CINAHL. This process is structured by the CSP CPD cycle, where we identify, plan, learn, apply, and evaluate, which promotes sustained development grounded in reflection and clinical effectiveness. For students, MacLeod notes that CPD is particularly useful in identifying gaps in knowledge and developing clinical reasoning. This enhances both care delivery and decision making, whereas the HCPC also outlines methods for engaging in reflective CPD, such as individual journaling or participating in group sessions like the Schwartz rounds, which help develop collective insight and shared learning. The author Maloney notes that reflective practice plays a vital role across healthcare. In allied health education, it is used to analyse and adapt to clinical experience, helping students and professionals restructure knowledge, define practice, and transform daily encounters into lifelong learning. The CSP physiotherapy framework outlines values that shape how physiotherapists behave, think, and deliver care. This includes taking responsibility for actions, behaving ethically, striving for excellence, and delivering safe, effective services. These values underpin clinical effectiveness, which refers to delivering care that is evidence-based, outcome-focused, and tailored to individual needs. They also support service development, where we continually improve practice through leadership, innovation, and collaboration. CPD plays a vital role in both areas by enhancing the 4 pillars of practice. These are clinical, maintaining safe evidence-based care; education, supporting reflective learning and professional growth; leadership, enabling physiotherapists to guide change and influence services; and research, encouraging clinical appraisal and evidence-informed practice. Through CPD, physiotherapists remain competent, confident, and prepared to respond to the evolving demands of healthcare. It empowers us to apply new knowledge, improve patient outcomes, and contribute to service innovation. The transition from student or support worker to graduate physiotherapist involves a clear shift in responsibilities. These include changing from following instructions to autonomous clinical reasoning, from supervised tasks to independent decision making, from assisting with care to being accountable for outcomes and documentation, from reflecting informally to engaging in structured CPD and lifelong learning. As an advanced support worker or a student, I've worked under supervision with defined tasks. As a graduate, I will be expected to lead interventions, justify clinical decisions, and contribute to improving services I work within. CPD supports this shift by offering structured opportunities to learn, reflect, and apply new skills. And this can be done through the CSP CPD cycle, where we identify, plan, learn, apply, and evaluate. Some of the drivers here as a student include the structured learning on placement, feedback, motivation, and progress. Barriers as a student include the time pressure from academic workload. Drivers as a graduate, of course, is the HCPC requirement for CPD, the accountability, and a desire for career progression. Barriers as a graduate would also include the clinical caseload, as well as limited protected time for CPD. I recognise that CPD will evolve as I take on more responsibility and gain autonomy in my practice. Thinking more about reflective practice, Johns describes reflective practice as holding up a mirror to our own actions, allowing practitioners to confront the gap between their professional vision and the reality of their practice. In order to act with greater integrity and self-awareness, or this helps us to act with greater integrity and self-awareness. Foote, however, highlights a key challenge. Individuals engaging in critical reflection can feel hesitant to revisit emotionally difficult experiences, particularly when they perceive reflection as exposing incompetence rather than fostering growth. Davis demonstrated that reflection can have measurable benefits. In a study involving cognitive behavioural therapy practitioners, a 10-week self-reflection workbook led to improved self-perceived skills, particularly in interpersonal empathy. That said, the study had notable limitations. The sample was small, it was non-physiotherapy specific, and had high dropout rates, which affects the generalisability of its findings. In contrast, Shin explored critical reflection within nursing, showing how it can help bridge the gap between theory and practice. The study found that reflective processes enhance clinical decision making and problem solving by encouraging practitioners to integrate theory, lived experience, and practical reasoning. While both authors provide valuable insight into the benefits of reflection across healthcare professions, Daly Hewer observes that examples of how physiotherapists use reflective practice outside of academic settings remains limited. Given those points, it's also important to remember that several reflective theories and frameworks are relevant in physiotherapy, including the Schoen reflective model and the John Dewey's reflective practice. In preparing this presentation, I have used multiple methods of reflection to strengthen the outcome. These include the 4Fs, the SWOT analysis, and Kolb cycle to identify gaps in my professional development and create actionable goals. These models have helped me reflect authentically on my experiences, learning needs, and evolving identity as a physiotherapist. Firstly, the facts. I started my professional journey early, entering art school straight from secondary education. After completing a fine art degree and postgraduate studies in museum studies, I spent over 12 years as a museum curator. That career offered rich experiences, including travel, fundraising, public engagement, and people management. but also brought physical and mental health challenges that eventually led me to reevaluate my path. Physiotherapy played a crucial role in my recovery from chronic pain, helping me to avoid surgery. That experience motivated me to pursue a career where I could help others overcome physical challenges and build a more balanced life. I began with an Access to Health and Biological Science course, then progressed to the BSc in Physiotherapy. Since then, I've completed placements across MSK, stroke rehab, spinal injuries, cardiac rehab, and elective orthopedics. These have gained me exposure in both inpatient and outpatient settings. Alongside my studies, I've actively worked in part-time roles across healthcare as a sports massage therapist in a private clinic, a healthcare support worker, a call handler for NHS 24, and now as a Band 4 physiotherapy assistant in orthopaedic trauma. These roles have strengthened my confidence, adaptability, and communication across diverse clinical environments. The feelings around this, transitioning into physiotherapy, has brought both excitement and discomfort. Coming from a creative and non-clinical background, I often felt like I had to justify my place. I've struggled with imposter syndrome and initially feared that my experience wasn't relevant. However, the process of learning, adapting, and contributing, especially in clinical placements and NHS roles, has helped me feel more grounded and capable. I now feel proud of the perspective I bring and grateful for the resilience I've built along the way. Findings: I've discovered that my past gave me highly transferable skills: empathy, public communication, critical thinking, and leadership. These qualities complement the hands-on critical skills I've developed through placements and assistant roles. I now understand patient care through multiple lenses, from structured clinical protocols to patient distress in real-world, high-pressure contexts. Still, I recognise a gap in my ability to confidently support patients dealing with low mood or fear, areas where I want to develop. In the future, my CPD priorities include developing skills in emotionally informed rehabilitation, behaviour change, and communication in emotionally charged situations. I'll continue to use the CSP CPD cycle to identify learning needs, apply knowledge in practice, and reflect meaningfully. I aim to bring together my personal experience, past leadership experience, and current clinical learning to become a physiotherapist who is not only skilled, but also compassionate, reflective, and has person-centered care in every aspect. As part of my critical reflection, I completed a SWOT analysis to assess my current professional development. Jasper describes the very similar SWOT method to help understand our skills and abilities and an awareness of where the limits of those lie. Among my key strengths are a broad range of clinical experiences, along with hands-on experience as a Band 4 physio assistant. I have developed strong skills in risk stratification, confidently identifying red and yellow flags, monitoring vital signs, which aligns with the HCP standard for safe and effective practice. I also communicate empathetically, using open-ended questions and active listening to support person-centered care in line with CSP values. My ability under pressure has been shaped by acute care placements, and I'm confident in carrying out structured assessments to set rehabilitation goals. However, I recognise several areas for development. I feel underprepared to support patients who are emotionally disengaged or experiencing post-operative regret, which highlights a gap in meeting HCP standards regarding psychological needs. I also lack confidence in prescribing exercise outside of set protocols, and I'm still exploring how to meaningfully apply the leadership and project management skills from previous careers in clinical contexts. Additionally, I've noticed a tendency towards burnout, often push myself too hard, a challenge to maintaining well-being as outlined in HCPC Standard 3. There are opportunities to address these gaps. I'm particularly interested in CPD around psychologically informed practice, which could help me better support patients emotionally. I also see potential in combining this with strength and conditioning knowledge, especially through courses like the UK Strength Conditioning Association to offer more holistic rehab. I plan to engage with professional networks like the Physiotherapy Pain Association and continue exploring research on the emotional impact of surgery and recovery. Of course, challenges exist. Financial constraints may limit access to some CPD, and I'm still clarifying where the boundaries lie between physiotherapy and psychological practice, which can affect my confidence in applying certain approaches. Additionally, not all peers may value psychologically informed models, and time pressures from caseloads may make CPD planning difficult. However, by recognising these challenges now, I can plan proactively and use reflective tools like this walk to guide my development as I transition into graduate practice. I've used Kolb's cycle of reflection to further narrow in on one particular experience. While in placement in elective orthopaedics at University Hospital Hairmyres, I was supporting several patients who appeared visibly distressed and expressed regret about having their operation. Although I was confident in carrying out the initial assessment and following the rehab protocols, I felt underprepared when it came to managing the emotional response. I attempted to reassure these patients, but I was unsure how best to support them beyond basic motivational interviewing. Later, when I reflected on this with my practice educator and members of the team, I was told that the appropriate response was to remind the patient that this was an elective procedure and that they had been given all the necessary information during joint school. The team's position was that the patient should feel well informed and accountable for their choice. This left me with the questions about how to respond ethically and empathetically in situations where patients express regret, especially in a culture that may not always validate emotional responses in acute care. Ultimately, these patients took significantly longer to rehab and discharge than others. From my reflective observation, I noticed that patients' emotional state, including regret and low mood, was dismissed by some staff. When I raised concerns with my practice educator, I was told that these patients had chosen this surgery and attended joint school, a 2 hour lecture on what to expect and should be well informed. I felt conflicted. While I understand the importance of informed procedures and patient accountability, I also felt that this approach lacked compassion and didn't address the patient's current needs. I began to question whether there was space within the team culture to support a more emotionally informed way of working, or whether I was overstepping by raising concerns. Um, it made me reflect on the balance between respecting team norms and advocating for a more patient-centered approach. Fay describes this as the barriers to rational change as tradition, force, and embodiment. In my abstract conceptualization, I've learned that supporting a patient's emotional recovery is just as important as their physical rehabilitation, especially in the context of elective procedures where regret or disappointment may arise. This experience highlighted the need for psychologically informed approach in acute orthopedic care. I now understand that my CPD must include emotional communication and psychological support strategies. I also learned that clinical knowledge alone isn't enough. The culture and attitudes of the wider team shape how care is delivered. While patients may have consented to surgery and attended preparatory sessions, informed consent doesn't eliminate the emotional complexity of recovery. This raised ethical considerations for me. Should we simply inform or should we also support? I realised that emotionally informed practice may challenge prevailing attitudes in some acute settings where time pressure, efficiency, and task focused care dominate. This experience taught me that while team culture matters, so does individual professional judgment, especially when it comes to compassion and communication. In my active experimentation, next time I'll be more proactive in applying psychologically informed techniques, even in small ways, such as using more open ended questions, validating the patient's feelings, and showing active listening without rushing into solutions. I'll also be seeking supervision of or informal debriefing when these situations arise. In the longer term, I will explore CPD opportunities that focus on communication, behaviour change, and emotionally informed rehabilitation, and continue using the CSP CPD cycle to structure my learning. I also aim to find a balance between respecting team culture and expressing clinical concerns that relate to patient well-being. Using these reflective cycles has helped me to identify the following SMART goals. Goal 1. Within 6 months of my graduate practice, I will complete a CPD course in psychologically informed practice and implement one technique in the clinical setting around the topic of post-operative regret and reflect monthly in my TURAS portfolio. Goal 2. For service development. Within my first year of practice, I will develop a short evidence-based resource, such as an in-service talk, on post-operative regret in elective surgery and its impact on rehab engagement, as well as discharge duration. This will include findings from current literature and psychological models relevant to physiotherapy. Both goals emerged directly from my co-reflection and built on the opportunities identified in my SWOT. To reach these goals, I would need access to workshops and seminars via CSP professional networks, for example, the Pain Association. I'll need time to read and review resources and clinical supervision, as well as peer support. As a final reflection, reflecting across multiple models has helped me understand both my professional growth and personal identity. I recognise that technical knowledge alone isn't enough. Emotional intelligence, person-centred care is critical to effective rehabilitation. Post-operative regret emerged as a key theme in my reflection, highlighting the importance of psychologically informed communication. I feel more confident in my ability to learn, adapt, and reflect through structured CPD. I'm committed to ongoing development that aligns with the HCPC standards, CSP values, and the needs of my patients. This journey has helped me to bring together personal experience, clinical training, and reflective learning into a clear vision of who I want to be as a physiotherapist. I've learned that it's not just about clinical protocols, but about how we respond to patients' emotional realities, especially in elective contexts where regret or distress may emerge. Through CPD and reflection, I'm building the confidence and capacity to offer compassionate, evidence-based care. I know this is a career-long process, and I feel more ready than ever to continue learning as I enter professional practice.